Okay, in our video series of neurology lectures, in this video, we are going to talk about multiple sclerosis. A 32-year-old lady comes to your clinic and tells you that, doctor, I am feeling numbness and tingling in my right hand. When you are taking medical history from that patient tells you that last year I had an episode of visual problem in my right eye. I had pain on eye movement. I had problem with vision, with color vision of my right eye. The doctors diagnosed me as a case of optic neuritis. But then I recovered from that. And with that, 2 years back, I had an episode of problem with walking, which was associated with urinary incontinence. So the patient is having neurological deficits, and those neurological deficits are not correlated with each other. The neurological deficits are distributed in time and space. Each neurological deficit is different from other, and that neurological deficit is occurring at a different time, and patient is recovering from that. That is a classical presentation of multiple sclerosis. What is multiple sclerosis? How do you diagnose it? How do you treat it step by step? Today we will talk about that. Multiple sclerosis is a chronic degenerative autoimmune disorder of CNS which is characterized by demyelination and axonal degeneration of spinal cord and the brain. Basically, what is happening is that the immune system is damaging the central nervous system. Immune system is damaging the neurons of brain and the spinal cord. Peripheral nervous system is not affected. It's the central nervous system. And what constitutes the central nervous system? It's the brain and the spinal cord. So the brain and spinal cord will be damaged, and all the signs and symptoms will be of upper motor neuron lesions. So it's an autoimmune disorder where the immune system is causing demyelination, destruction of the myelin sheath, and axonal degeneration, destruction of the axons of neurons that results to the damage to CNS and multiple sclerosis. It is more common in females as compared to males, and if you see, all the autoimmune diseases are usually more common in females as compared to males, and it is more common in females, young female 20 to 40 years of age. And an important point to remember is that it is commonly seen in people who are living away from the equator, meaning the people who are living in areas where there is more cold, in people who are living in cold climates. It is a disease that is associated with cold climates. And the hypothesis behind it is the vitamin D deficiency hypothesis. Since the people living away from the equator have lack of sun exposure due to cold, and that lack of sun exposure causes vitamin D deficiency, and it is a hypothesis, we do not know the exact cause, but it is a hypothesis that vitamin D deficiency might be related with multiple sclerosis. Now, coming to the cause of multiple sclerosis, the cause of multiple sclerosis is mainly genetic predisposition. Patients have a genetic history of multiple sclerosis, and with the genetic predisposition, the problem is there within the genes. With that, some environmental risk factors, some environmental triggers are also there, and those environmental triggers activate these genetic deficiencies, and they result in the expression of genes, expression of the disease. So environmental risk factors include low vitamin D levels, decreased sun exposures as occurs in the cold climate areas, cigarette smoking, Epstein-Barr virus. So these are the environmental risk factors that trigger these genes and cause expression of the disease. What happens is that immune system produces autoreactive T lymphocytes. T lymphocytes that damage the own body, and they cause destruction, demyelination of the axons. Now the axons of central nervous system are lined by the cells called as oligodendrocytes. In the central nervous system, the myelin sheath is formed by oligodendrocytes. In the peripheral nervous system, it is formed by the Schwann cells. And can you name the disease in which peripheral nervous system is damaged and it damages the Schwann cells? You can mention that in the comment section. We also studied that disease as well. I have made a video on that. But in multiple sclerosis, remember, it's the central nervous system and oligodendrocytes are damaged, and it damages the oligodendrocytes, it damages the myelin sheath, and when the myelin sheath is damaged, the electrical conduction of the neuron is impaired. That results in the neurological deficits. It causes loss of axon, atrophy of oligodendrocytes, which produces chronic plaques, and reactionary fibrosis of the brain takes place, and fibrosis of brain the fibrotic tissue is always useless tissue. It only covers up the wound, but it does not have any function. So it is a scar tissue that is called as gliosis, which is an inadequate repair that results in permanent damage in some patients. Now coming to the clinical presentation of multiple sclerosis. Clinical presentation of multiple sclerosis is very simple. Patient will be having focal neurological deficits, and those focal neurological deficits will be spread out in time and space. The word space means that every time different area of the brain is affected, therefore different neurological symptoms will be there. At one point, the patient will be having symptoms of the eye. At another point, the patient will be having symptoms of the hand. At another point, the patient will be having symptoms of the urinary bladder, or the patient may be having symptoms of the legs. So different spaces of the brain are affected, and different time distribution in time and space, and it is also distributed over a certain period of time. Patient might have a neurological deficit 1 year, and after a patient is then totally fine, and after a few years patient develops a different neurological deficit, and after a few months patient develops a totally different neurological deficit. That is the meaning of distribution in time and space of lesions. That is a classical feature of multiple sclerosis. Now, optic neuritis is most often the earliest manifestation. Basically, optic neuritis is the inflammation of the optic nerve. The optic nerve gets demyelinated and that optic nerve gets inflamed. It is the earliest manifestation, and the eye movement are very painful. So the patient, that case we had initially, that patient had an episode of optic neuritis where there is inflammation of the optic nerve and there is impaired vision, impaired color vision as well. Relative afferent pupillary defect RAPD will be positive, also called as Marcus gun pupil. Now what is RAPD? What is Marcus gun pupil? Normally when you shine light into the eye, the pupil will constrict, and when you swing the light to another eye, the pupil of the other eye will constrict. This is a normal reaction to the light. The pupils constrict in response to light. But in patients with RAPD, if this is the diseased eye and this is the healthy eye, when you shine light to the healthy eye, the pupil will constrict. But when you swing the light to the other eye, the eye will dilate, because this eye cannot perceive light because the optic nerve has been injured. That is called as relative afferent pupillary defect, and it is only examined when you perform swinging light test. And when you perform swinging light test, when the light is in the healthy eye, both pupils will constrict, and when you put the light on the diseased eye, the pupils will dilate. That shows that RAPD is positive and optic nerve has been inflamed, or optic nerve is damaged. Internuclear ophthalmoplegia. Internuclear ophthalmoplegia is also another eye finding. Basically, normally when our eyes move, they always move together. They always, when my right eye wants to look at the right side, my left eye will also move with it. That is called as conjugate eye movement. Both eyes move together. How do they intercommunicate with each other? Basically, there is a bundle of strong nerve fibers called as medial longitudinal fasciculus. Medial longitudinal fasciculus is a bundle of neuron that connects both eyes. So both eyes are connected with each other through medial longitudinal fasciculus. If the right eye wants to move toward the right side, it will signal through medial longitudinal fasciculus. It will send the signal to the left eye that we have to move toward the right side. So both eyes will move on the right side. But what if this bundle, medial longitudinal fasciculus, is injured, inflamed? In multiple sclerosis, this medial longitudinal fasciculus gets damaged, and when the right eye wants to move on the right side, the left eye will not receive a proper signal. So basically what happens is that in internuclear ophthalmoplegia, when the right eye wants to look on the right side, the left eye does not get a proper signal. Therefore, the right moves on the right side and left eye starts having nystagmus. It starts vibrating like this. Basically, the problem is that they are not having proper communication with each other due to damage of medial longitudinal fasciculus. That is called as internuclear ophthalmoplegia. So the eye findings are the earliest finding, and optic neuritis is the earliest finding of multiple sclerosis. Demyelination of spinal cord can also occur, and you can perform L-hermitte sign. What is L-hermitte sign? L-hermitte sign occurs that when you flex the neck, the nerves get stretched and there is a shooting pain down the spine on neck flexion. That is called as L-hermitte sign. Pyramidal tract lesion, the corticospinal tract, the corticobulbar tracts are damaged. So there is upper motor neuron lesions of the hand and legs. There is spasticity, hyperreflexia, upper motor neuron lesions, dorsal spinal column lesion. The dorsal medial lemniscal system is also damaged. Dorsal medial lemniscal system is basically a set of neurons that carries the sense of vibration, sense of fine touch from the hands, from the legs, from the body. And when the dorsal column medial lemniscal system is damaged in multiple sclerosis, there is loss of sensation from the body. Absent abdominal reflex. Normally when you scratch the abdomen, there is a reflex that the muscles of abdomen get contracted, but the abdominal reflex is lost due to demyelination. And remember, abdominal reflex loss is one of the early findings of multiple sclerosis. Neuropathic pain due to sensory nerve damage. Cerebellum can also be involved, and there will be ataxia, nystagmus, cranial nerve palsy, third nerve palsy, facial nerve palsy can be seen in multiple sclerosis. But remember, the last cranial nerves 9, 10, 11 are usually spared in multiple sclerosis. Autonomic dysfunction, urinary incontinence, sexual dysfunction is also one of the things that is affected in the early stages of multiple sclerosis, and patient might not express because he will feel ashamed of telling you that he is facing these problems. Uhtoff phenomena. What is Uhtoff phenomena? Uhtoff phenomena, whenever these patients get a warm bath or whenever these patients get a viral infection, it exacerbates the neurological findings. Whenever these patients get into a warm bath or whenever these patients get infection, these patients get exacerbation of the neurological findings, that is called as Uhtoff phenomena. Now coming to the phenotypes of multiple sclerosis can express in different forms, but the basic concept remains the same. The patient will have a neurological deficit spread over time and space. Patient can have relapsing remitting disease pattern, which is the most common disease pattern, as the name shows that the patient will have relapses of the disease in which the patient has neurological findings and then the patient is totally fine. Patient is totally healthy, and then the patient gets a relapse of the disease and the disease then remits and the patient is totally fine. The disease resolves. So there are phases of relapses with remission, relapses and remission. Exacerbations occur and symptoms remit almost completely between the exacerbation. So the patient that we had in our case that we had initially, that patient had tingling sensation in the hand. 1 year ago she had optic neuritis, and before that she had walking problem and incontinence, but in between those periods she said that she was totally healthy. So that was a case of relapsing remitting multiple sclerosis, and it is most common. 90% of the patients have relapsing remitting disease. Now this is a picture showing the exacerbations. These are the exacerbation. Patient gets the exacerbation, but then the patient is totally fine. Then patient gets another exacerbation. After that the patient is totally normal. Then patient gets another exacerbation. So relapse and remission takes place. That is the relapsing remitting pattern. Now coming to secondary progressive multiple sclerosis, most patients of remitting relapsing disease ultimately develop secondary progressive multiple sclerosis. And in secondary progressive multiple sclerosis, basically what happens is that if the patient gets a relapse of the disease, after that relapse, patient do not completely recover. Patient do not completely recover from that episode of exacerbation, and there is some residual neurological deficit left after the exacerbation. And then the patient gets another exacerbation, and after that exacerbation patient do not completely recover from it, and there is some residual neurological deficit left. So over a period of time patient starts accumulating neurological deficits, and those neurological deficits keep progressing, keep increasing, keep accumulating, and patient has neurological deficits all the time. Patient is not normal between these exacerbations, and this neurological deficit can increase independently of the exacerbations as well. So the patient gets an exacerbation, patient do not completely recover from it, and there is some residual neurological deficit. Then patient gets another exacerbation and patient has progressive increase in the residual neurological deficit. Patient gets another exacerbation and patient do not completely recover from it, and there is some residual neurological deficit. And so in between the exacerbation, disease is progressively increasing. The neurological findings are progressively increasing and worsening. That is called as secondary progressive multiple sclerosis. And 50% of the patients with remitting relapsing disease develop secondary progressive multiple sclerosis. Now coming to primary progressive multiple sclerosis, it is just the same as secondary progressive, But the only difference is that in secondary progressive, initially the patient has a remitting relapsing pattern, and that remitting relapsing pattern converts into secondary progressive one where there is accumulation of neurological deficits over the time. In primary progressive multiple sclerosis, patient from the very start has a progressive accumulation of neurological findings. Patient does not have that initial period of remitting relapsing disease. From the very start, the patient is having accumulation of these neurological findings, and there is progression of the symptoms and accumulation of the neurological findings over the time in between the exacerbations. So the only difference between secondary and primary progressive is that the secondary progressive disease has initial period of remitting relapsing that converts into secondary progressive. In primary progressive disease, from the very start the patient is having progressive symptoms. There is no period of remitting relapsing disease, and it occurs only in 10% of the patients. This is a graph showing primary progressive disease where the disease from the very start is increasing over the period of time, and there is accumulation of neurological deficits, and only 10% of the patients develop primary progressive disease. The most common one is remitting relapsing that gets converted to secondary progressive in 50% of the patients. Radiologically isolated syndrome. Basically what happens in radiologically isolated syndrome is that a patient was having MRI for another reason, and on the MRI you find a lesion suggestive of multiple sclerosis, and the patient is not having any symptoms. That is called as radiologically isolated syndrome. Clinically isolated syndrome. In clinically isolated syndrome, patient has a single episode of neurological symptoms and they are suggestive of multiple sclerosis. So you cannot exactly say that the patient has a distribution of signs and symptoms over a time and space, because that patient just had a single episode of neurological findings and they are suggestive of multiple sclerosis. That is called as clinically isolated syndrome, in which you have just one episode of neurological findings that point out toward multiple sclerosis. Now coming to the diagnosis of multiple sclerosis. In the diagnosis of multiple sclerosis, there is a Mcdonald's criteria. In Mcdonald's criteria, you have the symptoms that are disseminated in time. Over a period of time, the patient is having symptoms, the neurological findings, and dissemination in space. The neurological findings are affecting different parts of the brain. Each neurological finding is different from the other. There is a variety of neurological findings that is called as dissemination in space. So that is the Mcdonald's criteria for multiple sclerosis. Remember, MRI is the investigation of choice for multiple sclerosis. MRI is the main investigation for the diagnosis of multiple sclerosis. On MRI, what you will see is that you will see multiple sclerotic plaque in the periventricular white matter. Around the ventricles, you will see plaques of demyelination. Dawson fingers. What is Dawson fingers? We'll see that in MRI. Now this is a picture showing periventricular demyelination. This is the ventricle, and with that ventricle you can see these white patches. These white patches are the areas of demyelination, and if you look at these white patches, you will see that it's just like as if someone is pointing finger. So these fingers are called as Dawson fingers. This is another MRI showing periventricular area of demyelination. This is suggestive of multiple sclerosis. If the patient is having neurological findings and with that you find lesions like these on MRI, it is most likely multiple sclerosis. If you cannot do MRI, or if the MRI is inconclusive, then you can perform lumbar puncture. But remember, lumbar puncture is a supportive investigation. The main investigation is always the MRI. On lumbar puncture, what you will find is that you will find oligoclonal bands of antibodies. Oligoclonal bands are basically the antibodies. As I said, multiple sclerosis is an autoimmune disease that affects the CNS. So immune system will be producing antibodies, and those antibodies will be present in the CNS. So oligoclonal bands of antibodies, IgG antibodies, will be present in the CSF. It is suggestive that that patient is having multiple sclerosis. But these bands should be absent in blood. If these bands are present in the blood as well, it means that there is some infection in the body, and for fighting that infection, the body is producing antibodies. But those bands, if they are absent in blood and they are present only in CSF, it means that these are the antibodies that are damaging the oligodendrocytes of the central nervous system, and they are causing multiple sclerosis. So the finding in lumbar puncture is oligoclonal bands in CSF, and these bands are absent in blood. Now coming to the treatment of multiple sclerosis. In the treatment of multiple sclerosis, there is one therapy that controls the baseline disease, and in between the patient gets exacerbation, and during those exacerbations you give immunosuppressive drugs like steroids to suppress the immune system and stop the immune system from attacking the brain. So if the patient gets acute exacerbation, the first line drug is always high dose IV or per oral glucocorticoids. You give steroids, steroids suppress the immune system and stop it from attacking the brain. You rule out infection first, because if the patient is having infection in any part of the body, you cannot give steroids because steroids will further suppress the immune system and that infection can spread. So you rule out the infection first and then you give steroids. You give IV methylprednisolone 500 to 1000 mg daily for 3 to 7 days with or without short prednisone tapering. Alternatives include plasmapheresis. In plasmapheresis, you remove the antibodies that are attacking the brain, or ACTH hormone gel IM or subcut. Now these are only options if the patient cannot receive glucocorticoids. ACTH is a hormone that stimulates the intrinsic cortisol, intrinsic steroids, and they suppress the immune system. So the main treatment you should remember is that IV or per oral glucocorticoid steroids are used in the exacerbation. For the long-term management of the baseline disease, you give pharmacologic as well as non-pharmacologic measures. In the non-pharmacologic measures, you control all the risk factors, the environmental factors that were triggering these genes. So environmental factors are controlled. You ask the patient to have regular exercise. You ask the patient to stop smoking. You manage the comorbs. You give vitamin D supplementation. You go for symptomatic management. I'll talk about the symptomatic management in detail. In the pharmacologic management, certain therapies are initiated and those therapies control the immune system from attacking the body. The goal of the treatment is to manage the exacerbation and prevent the further exacerbation and slow down the disease progression. The disease that was progressing, you slow down the disease with this baseline therapy. In long-term management, you use disease-modifying therapies. In disease-modifying therapies, you have options like monoclonal antibodies. These monoclonal antibodies include natalizumab, ocrelizumab, lemtizumab. So these are the drugs. These monoclonal antibodies, basically these antibodies bind the WBCs that are producing these antibodies. They bind to the plasma cells and remove them from circulation, the plasma cells that are producing antibodies that are damaging the brain. So we use antibodies to catch those plasma cells that are producing these defected antibodies that are attacking the central nervous system. Platform injections include interferon 1 beta, glutaramine acetate. These are the drugs that have certain mechanism of actions that you don't need to memorize, but you should remember that these suppress the immune system and control the T-reactive lymphocyte attack on the central nervous system. In the oral therapies, we have fumarates, fingolimod, siponimod. So these are the drugs that control the immune system and stop the disease progression. These are called as disease-modifying therapies, and they are generally not recommended for patients who are pregnant or breastfeeding patients. An important thing to remember is that monoclonal antibodies have the highest efficacy. These antibodies bind to the WBCs and remove those WBCs from the circulation that are producing these defected antibodies. They have the highest efficacy, but the drugs that have lower efficacy, like interferon beta, glutaramine acetate, have lower side effects as well. So the drugs that have high efficacy have high side effects, and the drugs that have low efficacy have lower side effects. Now, according to the phenotype of the disease, we give the therapies. In relapsing remitting disease, you give interferon 1 beta, glutaramine acetate, and you can also use siponimod, monoclonal antibodies. In secondary progressive multiple sclerosis, all disease-modifying therapies can be used. In primary progressive multiple sclerosis, monoclonal antibody ocrelizumab is used. So according to the phenotype, the disease-modifying therapies are used. And when the patient gets exacerbation, you bombard the patient with high-dose steroids and suppress the immune system and control the exacerbation. In the supportive care, you screen the patient for major depression. If the patient is suffering from major depression, you start SSRIs, because this disease affects the central nervous system and there is high risk that these patients can develop depression due to multiple sclerosis. And other than that, most of the patients with chronic diseases ultimately develop depression. So you always screen patients with chronic diseases for major depression. If they are suffering from major depression and if their depression can be helped with medication, you may start the medication. Referral to physiotherapy, occupational therapy, and psychologists must be done. For urinary incontinence, as I said, autonomic findings is one of the early findings of multiple sclerosis. If the patient is having urinary incontinence, you advise bladder training, and you can give anticholinergics to the patient. If the patient is developing urinary retention, no, any of the findings can be there. If the patient is developing urinary retention, you train the patient for intermittent catheterization, and you can use bethanychol, a cholinergic drug that causes contraction of the bladder and causes urination. If the patient is developing spasticity in the upper motor neuron, if the pyramidal tracts are damaged, the patient will have spasticity of the legs and arms. In that case, you can use baclofen or tizanidine, that are the muscle relaxants. If the patient has damage to the sensory nerve, then that patient will be suffering from neuropathic pain. For that, you can use TCAs, amitriptyline, carbamazepine, duloxetine, gabapentin. If the patient is having walking problem, you can give walking aids to the patient. If the patient is having sexual dysfunction, you can advise sildenafil to the males and vaginal lubricants to the female. Before going into the summary, if you liked my video, please click on the subscribe button. We talked about what is multiple sclerosis, more common in females, vitamin D hypothesis, the etiology, genetic predisposition with environmental risk factors, autoimmune reaction that damages the oligodendrocyte, optic neuritis being the first and common site, internuclear ophthalmoplegia, demyelination of the spinal cord tract, cerebellum involvement, cranial nerve involvement, autonomic dysfunction, remitting relapsing phenotype of the disease, the secondary progressive phenotype, primary progressive phenotype, the diagnosis, Mcdonald's criteria, MRI being the main investigation, and the different phenotypes, acute exacerbation managed with steroids, long-term management include non-pharmacological measures and pharmacologic management. Pharmacologic management include disease-modifying therapies, and they are given according to the phenotypes. If you liked my video, please click on the subscribe button and check out my other videos on neurology lectures and emergency medicine lectures. The link of those videos is given in the description below. Thank you very much.